Hi, my name is Quinn Doan. I'm an emergency physician at the BC Children's Hospital, as well as a health services research scientist. So a few years ago, as an emergency physician, I started noticing an increase in number of kids coming into the department with a mental health crisis or mental health related complaint. Thing is, I didn't train in mental health. Neither did most of my colleagues in emergency medicine. So we're a bit uneasy as to our approach. Our assessment is quite varied. Our risk tolerance level is also very varied, and often we resort to relying on the psychiatry team to help us out. The emergency department is a chaotic environment. You want to be able to get the family in and out as efficiently as you can. It's not safe for them to hang around for a long time. It's not safe for anybody else around there either. So ideally, we'd get a proper assessment efficiently, direct them to the proper care in a short amount of time so that we limit the exposure to the emergency department.
In this training session, we will review the tools developed for the Child, Youth, Mental Health, Substance Use ER protocol. The intention of this protocol is to help you more efficiently direct the children or youth to the right care team. This process will shorten the time the youth will spend in the ER. The working group developed 5 tools as part of the ER protocol. Firstly, a what to expect pamphlet for youth and parents developed by them for them. Second, an algorithm for physicians and nurses to outline a clear process within the ERs from triage to discharge. The third step is a psychosocial assessment tool called HeartsMap. The fourth is a discharge communication plan, which acts like a referral form to community services and care teams. And the fifth is a discharge safety plan for the youth to take home that they helped develop. This information can be found on your internal health authority website as well as in your ER once implemented in your hospital. Each health authority adapts the forms to reflect local practice and local services. Let's start first with the pamphlet. The What to Expect pamphlet was designed by parents and youth for youth and parents in the ER at the start of their visit. This is given out at triage, and the pamphlet provides information on what their experience in the ER will typically look like and some local and provincial resources to help them. The next step is the algorithm. The algorithm has been designed to help hospital staff determine a clear path for a child or youth's movement through the ER, depending on their situation. Here's how it works. Once the youth is brought into the ER and settled, preferably in a quiet space if possible, check and take care of any medical concerns. Once they are medically stable, we can move on to the psychiatric assessment. The nurse, crisis worker, or ER physician will explain to the youth and parent that they are now going to complete the psychosocial assessment, which will provide the information needed to determine how to best care for their child. This is where the HeartsMap assessment tool is used. HeartsMap was chosen to help provide an accurate social psychiatric assessment as possible.
We built the HeartsMap, the psychosocial assessment tool for emergency clinicians, with a few principles in mind. So the first key principle is that the emergency department is not going to be able to diagnose and initiate or carry on long-term treatment for mental health disorders. The emergency's role is to assess what the needs are and to redirect families to the right care team so they can get ongoing care for their chronic problems. Second, not everything mental health is necessarily psychiatry. There's a lot of mental health crises we see that are originating from social problems. There's some behavioral issue, the child has been aggressive, but there's no psychiatric disorder. The psychiatrist is not the best person to deal with that. So it is our job to identify what the issues are and send the families to the right resources and the right treatment team to help the family with this. The third principle is that suicidality is a chronic risk. It's not something that we can fix in the emergency department for good. We need to address the imminent acute safety issues, but often suicidal risk is chronic, and we need to acknowledge that and ensure that the family has a good safety plan for the long term. Hospitalization is not the treatment for suicidal risk. It rarely ever is. The last key principle is to address the family's needs for reassurance, assessment, and information. Often, a family comes to the emergency department because they don't know what's going on and they're worried and they're not sure what to do. It does not necessarily mean that they need to see the psychiatrist that day or to be hospitalized. What they need is for us to do a thorough enough assessment in an efficient way in the emergency department to identify what the issues are and then redirect the family to the proper treatment team. This has alleviated a lot of family anxiety about needing to see a psychiatrist right away, because we know that there's sometimes a long wait time to be able to see a psychiatrist. But the family can focus on the immediate issues and deal with the team that can help them with the long-term issues. That goes a long way. HEARTSMAP is a psychosocial assessment tool and a decision management guide. It is an acronym that stands for 10 different sections of the psychosocial assessment. For each section, there are some questions that will be helping you get the information you need to score the severity of each of the area of the mental health history. This scoring will then go into an algorithm that will spin out some recommendations as to what type of services this family needs and what level of acuity as well. This will all be summarized in a report that can be part of your health records to document your emergency psychosocial assessment.
Now that you have completed and printed the HEARTSMAP report, the next step is to follow through with the recommendations. If the recommendation on the HEARTSMAP report is for psychiatry, it may suggest consulting a child and adolescent psychiatrist, may also suggest a crisis response team, which for most hospitals in BC will be an urgent referral to the local child and youth mental health services, or thirdly, it may be a referral to the child and youth mental health walk-in clinic. For substance use services, your hospital may have a substance use counselor who will attend the ER and can begin to support the youth. Otherwise, they are referred to the designated substance use service. Another service that is available is the Concurrent Disorders Program at BC Children's Hospital. If it is not a mental health or substance use concern, or if there are additional concerns, the recommendations may include referrals to a social worker, professional services, or to their GP. If you're going to do a psychiatric consult for management and you don't have a child and adolescent psychiatrist in the hospital, the first option is to contact your health authority on-call psychiatrist. If there's not one available, you could call the race line during business hours, or if it's after hours, you can call the child and adolescent psychiatrist at BC Children's Hospital. These last two numbers are in the psychiatry consult box. If the child or youth is ready for immediate discharge, we're going to follow these steps on the far left. I'll provide more details on the communication plan and discharge safety plan in a minute. Please review the report and answer any of the family's concerns and explain the referral to the community services. Regarding safety, you should know that safety questions are also embedded in the HEARTSMAP to help determine whether the child or youth will be safe at home if you discharge them. Your hospital may have additional safety questions regarding adults in the home with problematic mental illness or substance use, and if the child has adults who can provide responsible care. If you have safety concerns, call MCFD Child Protection and discuss this with them. If the youth needs further assessment by a psychiatrist, then the middle section is followed to either have further assessment in the ER if you feel their symptoms will reduce in the next 24 to 48 hours, or to admit them locally. Please take a moment to review this area. If the youth is already working with their local child and youth mental health team, you can consult with them. You may want to consult with the youth's GP or consult with a pediatrician. If the youth is in for substance use services, you may consult the psychiatrist or a substance use counselor. If the youth needs to be transferred to a higher level of care, you will need to follow the procedures on the far right. This will involve consulting with a psychiatrist, their GP, as well as consult with the Child and Youth Mental Health Office if they're a current client for further information. Transportation may need to be arranged and the LLTO policy followed. If they are to be admitted under the Mental Health Act, then follow your hospital procedure. Now we are going to discuss in further detail the communication plan and the discharge safety plan. We developed the communication plan to be an improvement on the various referral forms we were seeing and to allow for more information to be provided to the GP and to the referral source the child or youth is being connected to. This form replaces any existing referral forms to Child and Youth Mental Health Services, Substance Use Services, or Aboriginal Services. The communication plan is designed to be completed with the youth and family so they can understand what you're recommending and you can answer any questions they may have. This form is also part of their medical record. At the top of the page, youth and parents, caregivers are asked to give their phone numbers. The second number was requested by referral sources to make the follow-up process easier by having 2 contacts. Under discharge diagnosis, you can put a summary statement from the report. Next, complete the medications at discharge. Then we move on to the referral section. If it is a mental health referral and the youth can attend the local child and youth mental health drop-in clinic on their own, ask them to go to the next drop-in clinic and then check off the first box. Your child and youth mental health office will have information pamphlets you can give them to explain their services. If you have additional concerns and want urgent response from MCFD Child and Youth Mental Health or referral to a mental health crisis team, complete this next section. The Child and Youth Mental Health clinician will follow up within 2 business days to see how they are, if they need to be seen quickly or if they need to see their current clinician. If they are a substance use client and you are referring them to your hospital substance use service, mark this area and fax the 3 forms to the substance use service. This includes the HeartsMap report, the discharge safety plan, and the discharge communication plan. Complete the remainder of the page and sign the form. This communication plan aims to provide a more consistent information flow from the hospital to the care team. Ideally, the sharing of information will prompt follow-up by the community service and the GP. The discharge safety plan is the last step before discharge. We recommend that you consider giving the youth the discharge safety plan as soon as they come to the ER. Then have the youth complete the first 4 questions either by themselves, with their parent, or with you. In the 4th question, they can write down your recommendation, whether this is to follow up with the MCFD Child and Youth Mental Health Services, Aboriginal Services, or Substance Use Services. Then review the resources with them. Some of these are similar to those in the What to Expect pamphlet, and seeing this information more than once will help reinforce options available to them. Some of your patients will come to the ER first before checking out any community service. This information may encourage them to connect to those services the next time they need support. The 3rd part covers strategies for the parent caregiver to keep their youth safe at home. It is important to review this section as the parent caregivers may be scared and wondering what actions they can take and support available. The consent to share helps to make it faster to share information with their care team. The practitioner signs off on this form, and so does the youth or parent caregiver. A copy of this form is given to the youth or family member, and they may want to share a copy with the members of their care team. This team can include school counselors or private therapists that they may be working with. We have had youth keep this form in their wallets and share with their team. The next step is to fax the 3 items to the referral source and their GP. This includes the HeartsMap report summary, the communication plan, and the discharge safety plan. These are all part of the medical record. Just to review, let's look at the process for using the tools in the emergency department. The key steps are the What to Expect pamphlet, the algorithm to guide from triage to discharge, the psychosocial assessment to ensure they are directed to appropriate care, the communication plan for referral at discharge, the safety plan at discharge for youth to take home and share with their care team. The intention of this process is to improve outcomes for children and youth at the hospital and to provide the ER team with a best practice tool to support them in their delivery of care. I'd like to introduce Alex. Alex is a youth with lived experience who has attended several ERs.
My name is Alex Gerling. I study science at Stanford University, and I've also struggled with mental health challenges for the majority of my life. As a kid, I grew up in a normal household, great parents, money was never a problem, but I always was different than other kids. I reacted differently in other situations than them. I used to get angry and almost violent sometimes for no apparent reason. This caused concern, but my parents it was never concerning enough for them to go get help. As I became a teenager, I started getting into trouble, using drugs, getting into fights, and things spiraled out of control. When I was around 16, I was admitted to the adolescent psychiatric unit at Surrey Memorial. So an experience that was not so great for me was I came into the emergency room, I was feeling extremely agitated, and I was immediately placed on a stretcher right beside the ambulance loading dock. Now there were people running in and out, people screaming, noises beeping, and lots of light. This was extremely distressing for me as I was trying my hardest to calm down, and it made it extremely difficult to talk to the doctor when he came in to see me. Now I can understand why they did this because they had to observe me, but I've been in the emergency room before where they put me in another corridor or something where they can still observe me, but there's just less going on. Now, when I finally got to talk to a doctor, he came in the room with a clipboard and basically treated me like a checklist. What would be helpful in the ER in my situation was if the doctors built a well-rounded picture of my life rather than just my symptoms coming into the emergency room. Like I can come in saying I'm anxious, I'm feeling aggressive, and immediately I just get put in a room and that's what I'm there for. They don't look at, or it would help if they could look at what was actually going on in my life and changes that I have to make in my life, because for my particular mental health situation, medication wasn't the only answer. I had to go to counseling, I had to change my friends, I had to break off a relationship with a girlfriend, and a lot of other things. The key thing to my positive experience is when the nurse and the doctor told me that I could come back to the emergency room anytime I was feeling the stress and they'd be more than happy to see me. This gave me faith and hope that I was going to get better, and if I didn't get better, I could still come back and they would help me. I continued to come back to this emergency room several times until I got better.
For training on the HeartsMap assessment tool, please go to www.heartsmap.ca for training and registration as well as resource information. For additional training in child and youth mental health, please go to www.learninglinksbc.ca, which has 15 online modules on a variety of child and youth mental health concerns. Each module takes 30 to 60 minutes to complete, and if you complete the whole series, you will get CME credits.